Okay, there we go. Nice.
Good afternoon, everyone. Welcome back again to my podcast channel. I'm Dr. Win, and on my other side, I'm honored, excited, and having the privilege to invite Dr. Dave Sin into this podcast channel. He's gonna have do a presentation for us about the craniofacial sleep medicine. But before we do that, we want to read and his bio just really quick. It's really long, but I'm going to go short. Professor Dave Sin is a U.S. citizen, was born and educated and trained in England, UK. He holds a doctorate degree, including Doctor of Dental Medicine, PhD in craniofacial cleft palate development, and a third doctorate in orthodontist. So, Dr. Sin, it's an honor. I know you have so much accomplishment throughout your career. I just want you to just invite you, and just you can maybe add on a little bit about yourself, where you are now, and what you are up to. I know that you before we start the channel, you spoke a little bit about your company, the Rema Sleep .com, to educate dentists, dental professional, healthcare professional, just pull together to work on the biggest problem in the world right now is sleep medicine. So, Dr. Dave, Dr. Sin, it's an honor to invite you to here.
Well, great. Thank you, Dr. Lucas. Great for me to be here. It's a real pleasure. I'm looking forward to chatting with you and answering any questions. The main aim is to really share the message of, airway, breathing, and sleep, whether it's doctors, dentists, orthodontists, or general people, or people who are working with the professions. And so I'm very open to chatting with you tonight.
Absolutely. Would you give it the audience I know that you are teaching at UC at Stanford, and also you at other medical school. So tell us a little bit about your background in the past 30 years. I know you've been doing this for a long, long time, and this is amazing. I'm talking to the the grandfather of sleep medicine here. So thank you, Dr. Sin. Let's
Nice.
explore this. Let's explore this topic. This is passionate because a combination of growth development in human anatomy and orthodontist and sleep medicine. Now it's become more and more prevalent. And you mentioned before that it needs to be together with the team of medical professional dental people. It's not just you cannot just take care of this problem simply by a dentist or by an orthodontist or by someone else or by a medical doctor, because you are teaching this to medical people too. So
Correct, yes. So, the story really starts about 30 years ago when I came to the US. And the position that I took was at the University of Puerto Rico because they had this Center for Craniofacial Disorders. So we were looking at babies and children and young adults who had craniofacial anomalies such as cleft palate, cleft lip, or something more rare like Apert syndrome or Cruzon syndrome. And at that time, we were looking at a new technique called distraction osteogenesis. So we were working with the plastic surgeons, the orthodontists, speech pathologists, everybody working together. And we were doing these kind of new surgical procedures on these children. And one of the things I realized from looking at the results was that these children's airway had developed after the surgery. And the surgery really was a mid-face surgery to kind of correct the mid-face. So that's where the idea came from, to say that most people don't have a genetic abnormality. And if we redevelop the midface, then maybe we can address sleep apnea. And so, long story real short, that's what I've been working on since that time. And, with a lot of luck and, determination, we've been, I've got to say, surprisingly successful in terms of what we've done so far. There's a long way to go, but this is a great place to be at right now. It's very exciting.
wow, For the audience, like non-professional people, it might be a complicated topic today, but I can't wait for you to talk a little bit about the concept of craniofacial sleep medicine, because it's very broad term, but I'm sure that you can condense this into a little bit easy to understand why it's all together and it's related to facial and then airway space and the medical aspect, the physiology aspect. Dr.
Yes.
Wei,
Yes. Well, this is very important because, as I mentioned earlier, my background was working as a professor in a medical school, teaching medical students and medical residents, as well as dental residents and orthodontic residents. So I got a very broad kind of picture. So you can't take one piece and hope to solve the solution. So, for example, some people say, I want to do nasal surgery. Some people say, I want to do, wear a CPAP. Some people say, I want to use a mandibular advancement device. And all of those therapies are appropriate and they are very successful. However, we need to look at the patient's needs first before we decide which therapy is the most appropriate. So, really, in a nutshell, that is called case selection. And then when you come to the dental office or the medical office, if you are a provider of a dental device, the chances are the patient will end up with a dental device, even though it might not be the very, very best option for them. Or you go to a medical office, they may give you, a CPAP. It might not be the best option, but that's what you have available in the office, and that's what you tend to prescribe. So my idea is saying, let's be more broad, multidisciplinary, work as a team, and really start to look at, what is the underlying cause of this condition? If it's obesity, I want to get the BMI under control. I need a physician to help me with that. If it's the fact that this patient has a retruded chin or the jaw is recessed, maybe I need a dentist or orthodontist to help me with that. But you may have a patient who's both obese and have a retruded chin.
right.
I want to say, can we be a bit more broad and address the patient more completely rather than do like a jigsaw piece and hope that you find the puzzle and make it fit at the end of the day?
That is real intelligent concept, because nobody really want to address the comprehensive care like what you mentioned. And
Hmm.
I agree with you on in terms of like if you have an obesity patient and you're trying to do apply, and you seem to ignore the truth, you know.
Hmm.
So that's an awesome thing, and I'm sure you have taught and trained and did many presentation around the world for this kind of concept of systemic approach.
Yes. Yes. So when we talk about craniofacial sleep medicine, we have to say, how did you come up with these three words? Because of course we have medicine, which is a huge professional topic with all the different specialties. And inside of medicine, we have the specialty of sleep medicine. So these are the fellows and residents who are specially trained and become sleep physicians. And so the counterpart for sleep medicine is, quote, dental sleep medicine. And so there are academies out there who train dentists, and orthodontists in dental sleep medicine. But in my mind, that creates a bit of a division between sleep medicine and dental sleep medicine. It's like us and them, it's you versus me. And I think, no, what is the most appropriate, approach for a single individual patient? And so if you took up my background in craniofacial cleft lip and palate, we had a multidisciplinary team. And so we got very good results because we were working in close collaboration. And so craniofacial sleep medicine is a bridge. It's saying, here's sleep medicine, here's dental sleep medicine. Where are you going to meet? Meet in the middle, craniofacial sleep medicine. So now the question is, what do you mean by craniofacial? And the word I would say is basically head and neck,
Mhm.
because the airway, the breathing, speak speaking, swallowing, it's kind of craniofacial and then leads down to the throat, the larynx, the voice box, and also the airway. And so you can't make a single boundary and say, this is where I will stop. For example, think of the hyoid bone. It's just below the mandible, below the chin. Okay. Now, what we know about the hyoid bone is that it's diagnostic for risk of sleep apnea. So we look at the position of the hyoid bone, and we can say this patient has a low risk, no risk, or a high risk of sleep apnea just based on the hyoid bone. Now, my question is, how are you going to manipulate the hyoid bone? Well, the hyoid bone connected to the tongue, connected to the mandible. And so if you move the mandible, the hyoid bone also moves. So suddenly we think, okay, we can't do it in isolation. So let's put a device into a patient's mouth and say, was this beneficial to a patient? What happened to the hyoid bone? Well, generally speaking, if the distance between the hyoid bone and the mandible decreases, the chances are the airway will probably, improve in a patient, with a diagnosis of sleep apnea. So this is what I mean by craniofacial. You can't take one aspect and say, this is it. Now, let me take it from the other side. Let's take a patient who's a mouth breather. The reason why they're a mouth breather is because they have some form of nasal obstruction. They have no choice, but they have to breathe through the mouth. And so the idea is, well, shall I go to my ENT surgeon, physician, and get a diagnosis, get some treatment, maybe have some surgery? Or is there some other method that I could maybe consider? Well, the floor of the nose is the roof of the mouth. It's the same bone. So you can approach it from either inside the nose or from inside the mouth. And so again, the question is not really of, who's going to do it, but is what is the most appropriate, optimal option for this individual patient. So we'll have to look at risks, benefits, alternatives, and then make an informed decision to saying, in this case, I think we should do this type of therapy. That's what I mean by craniofacial sleep medicine.
That is really an awesome explanation to my audience, because now we understand that, how did you come up with the craniofacial sleep medicine? It's combination of everything, and in term of like, uh, I'm sure you have done the research, and you done the treatment protocol, diagnosis protocol. Would you elaborate a little bit about how do you approach to diagnosticate, and who should be the one see first, and things like that?
Well, that is an excellent question because really diagnosis is the key to success. We don't want to treat the symptoms. Okay, patient is snoring or they're sleepy during the day, but we want to understand what is the underlying etiology. It comes down to diagnosis. And once you have a good diagnosis, then you can formulate a treatment plan, and then you can say, here are the options that we can do. Now, craniofacial sleep medicine is going to follow the human body. The human body, the way it develops in utero is from the top down, craniocaudal. So if you look at a newborn baby, the brain is very large, and then everything else is developing, but the brain is very large, well developed at birth. Okay, craniocaudal. So then what happens is the brain is sitting on the cranial base, which is this skull base. And underneath the skull base, we have two important structures, the upper jaw and the lower jaw, the maxilla and the mandible. So the cranial base is unique because in every ethnic group in the world, whether African, Asian, Caucasian, whatever, everybody has the same brain volume, Homo sapien. Okay. But the difference is the shape of the cranial base. So people who are from, Europe, Middle East, South Asia, generally speaking, they have a long cranial base. And you can tell that by looking at the bridge of the nose here, it's kind of very sharp. Whereas people from North Asia, East Asia, people from Africa, generally speaking, they have a short cranial base. And so the bridge of the nose here is not as well developed. Now, that has no bearing on cranial or neural function, but it has an impact on airway, breathing, and sleep. Because the patients who have a short anterior cranial base, if the front of the cranial base is short, the maxilla is set further back, and they have an increased tendency for a class 3 malocclusion. Okay. If the cranial base is long, increased risk of class 2 malocclusion. And then if the cranial base angle is increased, the mandible comes forwards, and so increased risk of class 3 malocclusion. Now, according to dental sleep medicine, the preferred method is mandibular advancement devices. And it's been proven to be very successful. But my question is, if it's a patient with a short cranial base, a class 3 malocclusion, and they have a diagnosis of sleep apnea, where are you going to put the mandible? Are you going to protrude it even more? And this is why we take a craniofacial approach to saying, okay, if the mandible is not the cause of the sleep apnea, we have to look elsewhere. And the chances are, in those cases, it will be the midface. And so we need to do some kind of palatal procedure to allow the midface, the nasomaxillary components to be enhanced and improved for breathing. So I always start the diagnostic procedure at the cranial base. Now, that is a structural approach, but then we have to look at the functional approach as well. And the functional approach, of course, is the sleep study, the home sleep study, or the PSG, polysomnograph, okay? So if you have a patient or a potential patient or someone, as an individual, and saying, how do we diagnose that this patient has sleep apnea? Well, the first thing to do would be like a pre-screening or a screening, maybe with a questionnaire, to find out what is the risk of sleep apnea. And if the screening says there's an increased risk, then that patient will be referred to a physician for a sleep study. And when the sleep study has been read and interpreted by the physician, they will have a one-to-one meeting, face-to-face meeting with that patient, and say, here are the options that could work for you, and that could include a dental or orthodontic physician as well.
I see. Now, the in terms of patients seeing some dentist and some doctor, how do you recommend us to work together in terms
Well,
of
I
the
think that
diagnosis?
yes, it's a very, very good question. So it has to be some kind of like a referral system. So you have, colleagues that that you trust and you like, you're on the same wavelength. And so this is kind of like a referral. You can say that, if a sleep study needs to be done, the patient needs to be reviewed for systemic health. You can work, with hand in hand with the physicians who share the same or similar philosophy. So I think that is, one way to approach it.
So would you say that we supposed to diagnose, that a dentist will diagnose, and should we treat it first, or if there's only one thing related to dentistry, then we should treat it first. But if the combination of like obesity and other medical issue, should we treat it and then refer, or should we not don't treat it yet, but refer and talk about it and start the treatment?
Well, you have to start with the patient's main concern. So if the
Okay.
patient comes to the dental office and says, hey, doc, I've been told that I'm snoring at night
Mm-hmm.
and I want a mouth guard, let's just say that.
Mm-hmm.
Then what you would do is do a screening to find out, has that patient got an increased risk of sleep apnea? So, for example, Epworth sleepiness scale could be done. There's different questionnaires you can do for children. And based on the finding of that, you're saying, hey, you know what? You need a sleep study. The sleep study would probably be ordered by the physician. It just depends on a state-by-state basis, but let's say it's ordered by the physician, and then the sleep study has been read, and let's say the physician says there's a diagnosis of mild sleep apnea with snoring. Now the question is, how are you going to treat this? Do you want to have surgery? You want to have a CPAP mask, or do you want to have some kind of oral device?
Mhm.
So, once we have the sleep kind of study there and saying, here's what we're working with, then we can say, is this patient suitable for a oral dental device? And one of the things you can do is do a 3D cone beam CD scan. It goes from the top of the head all the way down to the bottom of the neck. And what we do there is we're looking for what is the site of the obstruction, what is the severity of the obstruction, and how much airway collapse are we getting? So let's say this patient decides, I think I'd like to have an oral device. Then you do a scan and you find that the mandible, for example, is retruded, or maybe the maxilla is constricted. You could, design a device that would address the point of obstruction in this particular case.
So when you do the device, you give it to the patient. Do you put that device and do another CT scan and see if the airway space actually help? Can we do that, or
You can do that. However, the size of the airway, although it's important, what's more important is the airway behavior in terms of what this airway is doing at nighttime. Because if you take the CD cone beam scan, the patient is standing up and they are awake and they are breathing.
Mhm.
So you get an idea of what's going on. But when that patient lies down and goes to sleep, the muscles are going to relax, the airway muscles relax, and then the airway can collapse during sleep.
Mhm.
Now, what these patients do, some of them, is they turn over onto their side. So some patients have positional sleep apnea, and some patients have a non-positional sleep apnea. So it means that, for example, if a patient is lying on their back and they get sleep apnea, then they turn to their side, and then the airway opens a bit, and now they can breathe again. So this is the kind of, details that we are looking for in terms of how does this patient respond? Because even though you think a mandible being pulled forward would open the airway, it's not as simple as that clinically. That's not always the case because airways behave differently.
Would you touch on a little bit about so many non-surgical approach for treatment, including the appliance, the CPAP machine, the disadvantage, and advantage, but also there are some device that on the market they market that, oh, you put on the hand and it help you to not only monitor your sleep pattern, but also it may do something about airway space. I don't really know, but I know there is a lot of device out there. And yeah.
So there you have to be careful because it's a consumer market. People are trying to sell whatever they can. Now, the big umbrella is wearable devices like a smartwatch, smart ring, these devices that you can wear on your hand or on your wrist when you sleep. Now, some of these they're pretty good because some of them can be like tracking your sleep. It's not a diagnosis, it's a consumer product, but it's useful. It's like when you go to the gym, you wear a heart rate monitor and you can see how fast your heart is beating. And so wearable technology is coming in fast and taking that big space. But the person who can make the diagnosis is the physician to say, even though you're wearing a sleep tracking device, I need to really understand the brain neurophysiology when you're sleeping to say what is the extent of your sleep apnea, if any. And the devices that are currently available through the physicians are becoming smart devices as well. And part of that will be AI will come in and help you, develop devices which will be less invasive, and probably more efficient in the future. So this is why it's such an exciting time. There's a lot of products on the market, but you have to find the ones that have been tested and shown to be reliable before, trusting what the device output is.
How do you evaluate a device? Would you consider looking at their development and track record through PubMed or some other articles? What are the scientist article that is considered like valuable for the professional people? We're gonna recommend a patient. Yeah, I'll check this out. I think this is something that you might want to try, or I don't know. Just can you give us some information about it?
Well, it's a moving target, and the data and the research and the findings keep on changing, and the technology is moving very fast. So, there are some tried and trusted methods which we all know are very appropriate. And so the bottom line is that it's evidence-based medicine. We're looking for data, looking for evidence to say, 10 studies were done on this particular subject of sleep apnea. Of those 10 studies, 4 were randomized clinical trials. And those 4 trials showed this outcome. So big data is what it's about. And because of AI in the future, we'll be able to really map in a lot of detail what devices, what they do, how they do it, and therefore which one is appropriate, because not all devices work in the same way. So, for example, if you wear a CPAP, the principle of CPAP is that it's going to blow air down your airway, a bit like a balloon, and prevent the airway from collapsing when the pressure is low. And number 2, take an oral device. The idea there is to actually hold the mandible forwards, and by so doing is to physically open up the caliber of the airway and prevent airway collapse. These are the principles, because each patient varies in their response, okay? And the surgical idea is that to say, well, I can actually move the components like the jawbones into a new position, or I can open up the nasal airway surgically to prevent the airway collapse. But the technology moves, and now we have the implants. So you have an implant placed in your chest, and when the diaphragm stops moving, you get a signal. The electrical signal goes to your tongue. The tongue comes forwards, and the airway opens up in these patients who have sleep apnea. So the idea here is to say more and more technology, new and different approaches will be emerging both now and in the future.
What an awesome summarize. Dr. Sin, would you explain again about the implant? How does that work again?
So this is it's called hypoglossal nerve stimulation.
Hmm.
The hypoglossal nerve is a nerve that supplies the tongue. So if the tongue falls back and it closes the airway, if you stimulate the nerve, the tongue will come forwards and open up the airway. So the question now is when to open the airway? Well, when you stop breathing.
Mhm.
So how do we know that you stop breathing? Because the diaphragm is not moving anymore.
Mhm.
So there's a sensor there to say, hey, the diaphragm is not moving. And then you will place, an electrode there into the tongue, and there will be a pulse kind of generator, signal generator. So when the diaphragm stops moving, the signal will go to the tongue, and the tongue will move forwards and allow the patient to breathe again. But that is a surgical procedure. It's like a pacemaker. It's placed in the chest. You wear it for the rest of your life. And so that is basically, what it's doing there.
Oh, that's the first time I heard. That's good to know. Very interesting. Um,
Yeah.
Now you mentioned a little about the surgical approach therapist. Can you elaborate? Like so advanced jar, right? And that's
Yes.
mostly with uh medical doctor or oral surgeon.
Yes, the craniofacial surgeons, maxillofacial surgeons, oral surgeons, the ENT surgeons, there's a lot of surgical colleagues that can do various procedures for sleep apnea. Now, the surgical option, you know, it is an option. It can be quite expensive if it's not covered by medical insurance. So the implant procedure, for example, the cost will vary between, I don't know, 30,000, 40,000, maybe more, and it may or may not be covered by medical insurance. So the surgical options, the thing about the surgery is that it's irreversible. Once the surgery has been done, you can't move things back. And so you got to be, a little bit careful when you have these surgical procedures done to make sure that you're going to get a high chances of a good outcome. And there are many, many good surgeons out there. But in my mind, I would leave that as my last option. If the other things don't work, I'd like to be non-invasive, non-intrusive as far as possible, and work with the body and allow it to heal itself to a large extent. So, for example, if you have a patient who is obese, how is the obesity causing sleep apnea? You say, hey, my tummy is a bit heavy, why am I getting problem with my sleep? Well, all of the adipose tissue, the fat that is in the abdomen, is actually going to put pressure onto the thorax, onto the chest. And what it does, it reduces the lung volume. So this patient actually has to work harder to breathe because the lung volume has been decreased because of the excess fat. Now, this excess fat can actually move from the abdomen and be stored around the neck. So some people have like a double chin. All right. And so this double chin, this excess fat in the neck is going to put pressure on the airway and increase the risk of collapse because the fat there is heavy and resting on the airway. So if a patient has airway, breathing, or sleep issues and they are obese, number one is to say, you know what, let's get into shape. Let's lose, 10, 20, 25 pounds, whatever it takes. And let's see the effect on the sleep apnea because there can be a dramatic effect by getting your BMI, body mass index, under control. So that would be, quote, a kind of simple approach without any surgery, without any drugs, with no devices. Okay. So again, tailor the approach to the individual patient. Everybody doesn't need the same device, different devices for different people for different reasons. And that, I think, is the general kind of picture that's emerging.
That is really a great summary and explanation, Dr. Sin, for the audience to understand the concept of you know go with what you have at the patient present to you with medical condition, the weight problem, and even the mental condition that should be addressed as well. It's a combination of that too.
Well, I think that's very important because sleep has an impact on all the systems in the body, including mental health.
Mm-hmm.
And so we have to think about sleep apnea, which is when you stop breathing at nighttime and it prevents you from sleeping. On the other side, you have insomnia, where somebody finds it difficult to fall asleep or remain asleep. And so there's combinations where you have both sleep apnea and insomnia. So if the patient goes to the dental office or orthodontic office and says, hey, doc, I feel sleepy, I'm snoring, the first idea is, well, you must have sleep apnea. But this is why the sleep study is so important. The physician can decide, does this patient have sleep apnea, have insomnia? Is it a combination of those, or is it something completely different, like narcolepsy or REM disorder or something else? And so, for brain health, now children need to have a good amount of sleep because memory consolidation occurs during sleep. And if you're not getting good, restful, restorative sleep, you don't feel good during the day, your learning ability, educational achievement is going to be at risk. And also the behavior will not be ideal because this patient is actually wants to sleep. They've had deficient sleep. They have sleep debt. So it does have an impact on, on mental health. So for children, young people, really want to get them into a habit of, a really nice routine, a wind down period. The devices are going to go off. You're going to get ready for bed. And then at 9 o'clock or whatever time works for you, bang, that is bedtime. Now, why is that so important? Because of these devices, cell phones, laptop, tablet, whatever device you have, they are going to suppress melatonin. The blue light is going to suppress melatonin. So when it starts getting dark outside, your body starts producing natural hormone melatonin. And melatonin really is the alarm clock to say it's time to get ready to sleep. We use an alarm clock to wake us up in the morning, but the body is the other way around. It tells you when is the time to get ready to sleep. Melatonin. Now, with the devices, the blue light suppresses melatonin, so the brain doesn't feel sleepy. And then the child, young person, can't sleep well because the brain was out of sync. Now, you say to the child, it's time for bedtime. These children, they sneak the cell phone, the computer, the laptop into the bedroom. So there should be no devices in the bedroom. The bedroom should be quiet. It should be dark, a little bit cool, and allow you to get, restful sleep. In the ideal situation. Now we don't have an ideal situation. We have traffic noise, we have light pollution, we have air pollution. There's a lot of stuff going on, but we have to try to optimize and maximize our sleeping routine. And this is called sleep hygiene, allowing yourself the best possible night's sleep to get ready for the next day. The other thing about children and young people is their diet and what they are eating. So what you eat, when you eat, how much you eat, is it going to affect your sleep? And what we're finding is that if this child or young person is on fast food, junk food, processed food, the chances are they will not have a good sleep routine. And so what we want to do is what you do during the day affects how you sleep during the night. And so there's a lot of general stuff we can do to optimize the quality and the quantity of sleep without even going to devices in the first place.
That is so good suggestion, education for parent
Mm,
about for the kid, Dr. Sin. I'd like to touch base on the concept of orthodontist and non-extraction and extraction
mm,
and since you are multi-specialist, would
yeah,
you touch on the concept of should the if the patient need to have the teeth removed, should the orthodontist do the airway study, the sleep test first before they start doing tooth extraction? Or how do we work together? Because I have one incident that my patient came from far away, and she came because I interviewed one of the doctor that specialize in non-extraction orthodontist, and
mm,
the patient had to have expansion and replace back the two premolar that
mm-hmm,
her other orthodontist removed. So
right.
after she get that restoration again, she
Mm,
felt much better. She slept much better, and
mm-hmm,
so what do you think
yeah,
about how do we
yeah.
approach it for that?
Well, again, ask the body to find out what is it that makes a human healthy? What makes a human survive? What gives a human a long life longevity? And then you look at the human body plan. We are symmetrical on the outside of the body. Okay. We are asymmetrical on the inside of the body. Okay. Of the like the chest and the tummy. And what about the teeth? The teeth are inside the body, but actually the enamel is derived from surface ectoderm, which means technically speaking, the teeth are on the outside of the body. And so teeth are supposed to be symmetric. That's number one. Okay. Number two is we look at human development, we look at human evolution and look at the evolutionary record. What do we find is Homo sapiens at the beginning had 32 teeth, all of them, all the time. Now, there was some exceptions, you had genetic mutations, some teeth are missing, but generally speaking, 32 teeth is the human body plan for the dentition. 10 fingers, 2 eyes, 32 teeth. That is our human genome. The teeth are genetically determined saying you will have 32 teeth. That's a starting point. Now, real life, the child walks into the orthodontic clinic, into the dental office, and the teeth are crowded, and there's not space for all the teeth. My question is, why are you blaming the teeth? Genetically, you're supposed to have 32 teeth. It's not a tooth problem. The problem must be somewhere else. And generally speaking, the issue is that we have small jaws. The jawbone is small, and therefore there's insufficient space for the teeth. Then the idea is, well, let me extract some of these teeth and align those teeth up, and then, we'll be fine. Well, when we extract teeth, the bone that supported those teeth is going to be lost, is going to be resorbed. And so that is number one that you have to think about. But number two is the idea is that in the way I was taught, old fashioned, was extraction and retraction. That's how I was taught.
Mm-hmm.
You
Mm-hmm.
extract the first three molars, retract the canines, the cuspids, and then line everything up. That's how I was taught.
Mm-hmm.
It looks okay cosmetically, but the downside is that you've decreased the space for the tongue.
Yeah.
Okay. You
Yeah.
may decrease the size of the nasal cavity if you
Mm.
do retraction. So the idea is it's not the fact that you are extracting teeth that is the issue. The issue is that you are retracting the tissues
Mm.
and therefore impinging on the airway, breathing, and the sleep. So if you look at the big studies, the idea that tooth extraction is related to sleep apnea is weak, is very weak.
Mm.
But if you look at the techniques that were used in the orthodontic retraction, then you get a big better picture of what's going on here. It's not about the teeth, but it's the architecture that you finish up with at the end. So now if you have to extract a tooth, well, it's your professional judgment. But let's think about wisdom teeth,
Mm-hmm.
because generally speaking, people have wisdom teeth taken out without really thinking about it.
Mm-hmm.
Now remember, 32 teeth. So why do we extract wisdom teeth without really thinking about it? Well, historically, they were a source of, infection, and, in rare cases, they could cause death through infection. But those days have gone, but we're still extracting wisdom teeth historically for historical reasons. Now, if you look at people who play sports like footballers, ice hockey, or soccer players, especially women, they have a high rate of concussion.
Mm.
And so the idea is that if you have a large surface area, large occlusal area, if you get a blow to the chin, you can dissipate the force with a large occlusal area, and therefore you protect the brain. Now, if you're extracting teeth, the occlusal area will be decreased, so there may be an increased risk of concussion.
Mm.
So instead of doing that, the idea is to wear a mouth guard. Boxers wear it, footballers wear it. And we did one study in high school footballers, and what they showed was that the guys who wore the mouth guards decreased the risk of concussion in those cases. So tooth extraction is, it's a controversial kind of topic. So you have to look at it really carefully to say, you know, what is the impact on craniofacial health? That's brain health, that's airway health, and also facial cosmetics.
Yes. So you agree that we have to individualize looking at the patient airway space profile and also the chip complaint and all of that, but the concept of tip remove and retracted can be a problem. You agree on that?
Yeah, I think retraction is probably not the way to go because if you, again, the way I was taught prosthetics
Mhm.
is that you push the mandible back to take the jaw registration. And so, it was called a ligamentous position. And the jaw was retruded, and they said that is a repeatable position, and that's what we're going to go for.
Mhm.
But in fact, the jaw does not need to be retruded.
Mhm.
There's many studies on the TMJ, joint health, and people with TMD issues and problems. The
Mhm.
problem is the jaw is being retruded up and back. It needs to be downwards and forwards. You have more joint health, you have better airway health, you've got more space to work with. And so the idea of retrusion or retraction is probably not the way that we want to go. The face wants to go upwards and outwards, have really nice cheekbones, mandible can come forward, you have a broad arch, a broad smile. So brain health, TMJ health, upper airway health, all of this is a kind of is architecture which we're trying to achieve.
A lot of people, dentists that let's say they don't do extraction, the case kind of flare out. Um, what do you say to those cases? Is that okay or not okay? Or I mean, they look fine. They look okay when the patient smile. A lot more airway space, but the
Right.
people would say that, oh, you're going to create a lot of uh, the potential bone loss, facial bone loss.
Sure. Well, again, ask the body. Ask the body, what is it that you would like me to do? Well, let's ask the incisors, what do you would like me to do? The incisor, the job of the incisor is to incise. So it's like a scissor, it's going to cut. So lower, upper and lower incisors are going to incise. So those incisors need to be at 90 degrees to each other to be able to incise.
Mm.
The question is 90 degrees to what? So the upper incisor should be at 90 degrees to the cranial base. The lower incisor, 90 degrees to the mandibular plane.
Wow.
That means you get 90 degrees. So now I know, asking the body, where do you want the teeth to go? The body tells you this is where for function. Okay.
Mm.
Now, which are the first teeth to erupt? Lower
Lower
incisors,
expensive. Yes.
right? So
Yes.
you start putting the building blocks in place straight away at the beginning, saying, now I can incise, but now I don't want to overclose. So what I'm going to do next is erupt my molar teeth and establish the vertical.
Mhm.
Now, these teeth are precisely engineered genetically, historically, evolutionary, in any way you look at it, they are very precisely engineered. Cusp fossa relationship. We look at our first permanent molar tooth. It's the biggest permanent molar tooth in human history. If you take this tooth and go all the way back, it only had 3 cusps. It was called a trigone. This tooth got bigger with evolution with 4 cusps, the talon. Now you got 4 cusps. And then what we did became Homo sapien. We have the Dryopithecus pattern, 5 cusps. And as we keep on becoming even more evolved, the cusp of Carabelli.
Mhm. Mhm.
So now we've got this extra little cusp, like
Yes. Yes.
so these teeth are not getting smaller, they're getting bigger and bigger.
Right. Right.
Why do we have big teeth? Well, we got big brains, so we have to protect our big brains by spreading the occlusal kind of forces, right?
Mm.
Now, for big teeth, you need big bones, big jaw bones.
Mhm.
Why? Because this big brain needs a lot of oxygen, so you also need a big airway.
Mhm. Mhm.
Nothing is by accident,
Right.
okay? So the cusp fossa relationship of the first permanent molar tooth establishes where we're going to go. Every human class one occlusion, dental occlusion throughout history.
Mm-hmm.
So even though you got prognathic jaws, the teeth will still be in a class one occlusion. And if you can manipulate the bony architecture to allow you to achieve that, okay? So the teeth can be flared out, but it may not be, you know, you can't kind of sustain that condition for a long period of time without paying some kind of price. Now, bialveolar protrusion.
Mm.
Why are these teeth flared out? This is developmental compensation.
Mm-hmm. Mm-hmm.
This is the best position I can give you based on the environmental factors that I encountered as a child. So you look at a child, African American child, maybe African Asian child. Sometimes you see this protrusion because they have a short cranial base phenotype.
Mm-hmm.
If you don't develop the midface sufficiently, the teeth will
Mm.
incline to try to keep the incision, yeah, the function, in place.
Dr. Sin, really maybe one or two questions before we close up, and I will definitely invite you to go a little bit deeper each topic later on. But
Hmm.
is it the same concept that a lot of general dentists they do full mouth rehabilitation? They raise the bite. When raising the bite, the raising the occlusion, do you feel like it would help the airway space, or that not quite significant enough to consider?
Well, it's you again look at the individual case. Now we
Mm-hmm.
had a case who came in with a history of bruxism.
Mm-hmm.
The teeth were worn away.
Yes.
The gentleman wanted to go to his daughter's wedding. He said, "I want to have nice teeth."
Mm-hmm.
So he had a full mouth rehabilitation done. It looked
Mm-hmm.
great,
Mm-hmm.
but his comment was, "Wow, I'm sleeping so well."
Mm,
So the vertical does make a difference. We have pretty thick enamel. Our enamel is the thickest in human history.
mhm.
So we can't just look at the AP or the lateral. We have to look at all three dimensions and 6 degrees of freedom. So the vertical can be an important component. It's probably one of the most important components to look at in dental occlusion.
Yes, that's beautiful. And I love you are so knowledgeable, comprehensive knowledgeable in every aspect of dentistry. We haven't touched about concept of oral appliance for pediatric kid, and I'm sure it's a topic that you can talk a lot about.
Yeah,
And
absolutely.
yes, but Dr. Since it exactly about an hour, I am so honored and so thankful that you joined this, and this podcast is going to help a lot of audience. Before we stop, I know that we talk a little bit about your company and you are teaching uh, dental professional people about sleep medicine. The company
Yes,
called Rama Sleep.com. Rama is basically is almost like the deepest sleep of the phase of sleeping, right? So Rama
correct.
Sleep. So REMA sleep.com. And
Correct.
would you share a little bit about how long you've been established the company and your yeah.
It's very new. It's very new because there is a demand, there is a need for education and information. My job is to get this message out to many people,
Mm-hmm.
doctors, dentists, orthodontists, professionals. I really don't mind if you are, any branch, oral myofunctional therapy, dental hygienist. I really don't mind as long as you have the same focus. It could be somebody from an ENT background. But the point is that we have to be on the same page to say, okay, what's the best options for our patients? And so the real kind of idea behind this rema-sleep.com is to say, how can we help to give your patients more choices? And if I can help you in terms of maybe doing some, treatment planning, that kind of idea, and sharing educational information as well, with publications and videos and that kind of stuff.
That is definitely invaluable information for us at the dentist. And the more you become a dentist, you want to be so helpful for your patient. You don't want to just like, oh, I don't have enough information, and then just skip over and just talk about teeth. But uh, I've been doing this dentistry for 22 years, and I just feel like you don't want to focus on teeth only. You want to focus on the overall health of a patient, and
Yes.
how do you help them just not just just clean their teeth, do some braces or do some kind of cosmetic procedure, but give them something that, like you mentioned, like uh, uh, make them sleep better, or that,
Yes.
and that mean that make their health better, that mean that
Sure.
help their blood pressure better, that mean that
Yes.
help them their mental health better and confident and all of the stuff together. So Dr. Sin, I
Hmm.
just want to thank you again, and I love to see you again. At the end, maybe I will invite you for the we have a lot of dental organization that I will honestly invite you to join the board, join the teaching team and everything. So Dr. Sin,
Sure.
thanks again, sir.
Well, thank you for having me. It's been a real pleasure for me. It's been great meeting you, Dr. Yoon, and we shall definitely keep in touch.
Have a good day, sir. Take care, sir.
See you. Bye bye.
Thank you. Yeah, thank you.